Hello, my name's Joel Dunning, and in this set of slides I'm going to give you all the evidence in favour of pectus excavatum surgery. I think if we're going to fight the incorrect and unjust NHS Clinical Commissioning Policy, we all need to know the mistakes that they made. So I'm going to go through all the papers. I'm first of all going to go through all the NICE guidelines papers because they did a really good job of a literature review, and then I'm going to go through the NHS Commissioning Policy and the very tiny number of papers they reviewed and all the mistakes they made, and then I'm going to show you all the papers that do show a benefit for surgery. So I hope it's a benefit. I hope it helps us to get pectus back where it belongs on the NHS, and I hope you find this interesting. So let's start with the NICE guidelines in favour of pectus excavatum surgery. Of note, all this is pectus excavatum. So in 2009, NICE, which is our most established guideline development agency, been in existence for over 20 years, did a really good literature review for patients undergoing pectus excavatum surgery. The NICE recommendations came out saying that that the evidence for safety and the amount it worked is adequate to support the procedure. They said that we really should be doing it in hospitals with cardiac surgical support because of the rare complications, and that surgeons should be trained to do it, and we should have mentors if we're junior in this. So how did they do their literature review? They did a really good job, as NICE always does. 3,000 patients, 10 case series, a case report, and they actually approached UK surgeons and looked at a 260 patient registry as well that hasn't been published. They did a really good literature review. They looked at all databases, but they did the databases all the way from their start dates. So that was in most cases from 1966. So completely comprehensive review. They had looked down all the papers and they selected 12 for full review, but they also documented 50 additional papers. They did tabulate them and they told us all about the evidence contained in those additional 50. So actually 62 papers in this recommendation, of which full were fully reviewed. And their outcomes basically were pretty impressive, really. You know, they said, you know, really good cosmetic results, really good quality of life improvements. And I would say they spent a lot of time looking at adverse events. It probably was a bit more of a safety analysis as well as a does it work. And they found there was a metal allergy rate, there was a 1% infection rate, and that adverse events did exist but were very rare. Now, they get specialist advisors in and they ask the Association of Paediatric Anaesthesia and the British Association of Paediatric Surgeons and our own SCTS. So I'm just going to go through their papers, all the papers they selected as the most important, very quickly, but I think it is important to know what evidence NICE looked at. So the first one was looking at our UK registry, 2000 to 2008. They got 260 patients. These are UK patients in all our major UK centres. They found no major complications, a few little minor ones, a bit of bar migration, all the things we do rarely see that can all be fixed. Nobody died, and really importantly, very high satisfaction rates. People were very happy with the surgery and found benefit. They then reviewed some of Donald Nuss's papers. They reviewed two. In this one, this was 668 patients, you know, huge numbers. And again, excellent cosmetic results, very happy patients, no deaths, and very rare complications. In Donald Nuss's second series, published slightly more recently after that, 947, there might have been some overlap, but this paper had a slightly different emphasis. This was looking at cardiovascular impairment, and really very strong findings coming from this. 88% they could find echocardiographic evidence of compression, 89% they could find CT evidence of cardiac displacement, and they did show impaired respiratory function, and 15% of patients had some mitral prolapse. Park from South Korea. The South Koreans do a lot of pectus surgery. This was mainly a how safe is it study. Again, big numbers, 322, one cardiac perforation. That's horrible, but big numbers, and this was fixed, repaired successfully, and a 91% satisfaction rate. This was a multi-center study, Germany, Switzerland, Poland. Really good outcomes, sort of very happy with their outcomes as patients, and one liver injury. The other complications were minor. Castellani from Austria, 167 patients. I couldn't find too much more about this one cardiac injury requiring thoracoscopy. Of note, if a cardiac injury needs thoracoscopy, not thoracotomy or stenotomy, it couldn't have been that bad really. And there was one liver injury, but no other serious adverse events. This Canadian study, 2008, 43 procedures again, no major complications, and good benefit in health-related quality of life, which is very positive. Metzelder from Germany, 45 patients, getting smaller the series, but they did questionnaires, quality of life outcomes, and patients were improving. Again, high approval ratings from the patients, better self-esteem, better quality of life. This study from Poland was really big, 461 patients. This was mainly for safety, this paper, and 4 patients had a damaged pericardium. That's not a heart, that's a pericardium. No actual cardiac punctures, and no deaths. So this showed good safety. There were some bar rotations, a few pleural effusions and things, but nothing severe or important there. This one from the USA, 863 patients, really big, some metal allergies, some infection rates, nothing really serious, and no deaths. And BOUCHARD from Canada and USA, 2 centres. This was maybe the most concerning paper that NICE looked at very carefully, but this was a paper going around looking for have there been any really bad complications, and these were really bad complications. I would want to make the point that that 3 were basically redos, 2 redos from previously not well performed surgery, and 1 was a revision of one of their operations. So that's a very different if you're doing NUSS procedures in redos compared to a first time. So it's only the 4th case that was a first time procedure, but there was 1 death and 1 person that survived but with bad brain injury, and the other 2 survived. So that was about the worst in that series. So that's it. That's the NICE full documented papers for which they said NUSS procedure and Pectus should be commissioned. It's good, it just should be safely done in centres that have cardiac surgery support. So now let's move on to the Clinical Commissioning Policy of 2015. So as we all know, it came out saying that we should no longer commission Pectus surgery in England. And I want to go through it in really big detail because it massively contrasts with the NICE guideline, and they've made some massive errors in it. First of all, they rejected the NICE guideline, which I found very surprising. But secondly, they then didn't review any of the patients in the NICE guideline. They said that the NICE intervention guideline says that it's effective, highlights the risks, but then it says they did not provide further evidence to support benefit. Well, I've just gone through with the papers with you. It showed loads of health-related quality of life benefits. There were very big numbers. Remember, 3,000 patients and a 260 patient database registry from the UK. So I don't see how they've come to that conclusion. But the disaster of the commissioning policy is A, they rejected the NICE guideline, and B, they decided not to review any of those papers. So this is what NHS England did for their NHS review. Again, something very strange has gone on here. In 2015, Turnkey did the evidence review for them, and then there was a judicial review of the whole process, and it was delayed for about 3 years, and then they had to redo it. So they got a different company called Solutions for Public Health to redo their literature review, and they seem to do a more brief job. So can I just make an important point that in the evidence review, they are looking for quality of life papers. Secondly, on that left-hand side column, they said that if you get to less than 10 papers, you can look for studies of less than 50 patients, because they did have a 50-patient limit. They also went for only a 10-year, rather than looking at all the evidence forever, they did a 10-year, the last 10 years. Now, why papers older than 10 years are not relevant is beyond me. Then when they redid this, they moved the goalposts a little bit. So on the right hand side, they'd said all types, but case series where n is less than, they've actually even got a typo. They said less than 5, they actually meant less than 50, because they refused to review any less than 50, even though they said if they got less than 10 papers, you should open it out. It's only the last 10 years. And really importantly, they only looked at quality of life. They actually excluded cardiovascular papers. So let's have a little look at the papers, the only 6 that NHS England looked at to come up with their policy. So the first one is by Kelly. It's really good. It's 11 hospitals in the USA. A big number of patients, well, 264, smaller than a lot of the ones that NICE included, minimum invasive or ravage, and every single outcome measure, massive benefits here. A p-value in the 1 in 1,000 chance of getting it by error, really, really small. Actually 1 in 10,000, sorry, chance of getting it wrong. So body image better, emotional difficulties reduce self-consciousness, 97% in approval ratings of their patients. So that is really good evidence of benefit psychologically. Now in the NHS England policy, it says, and this is cut and pasted from the 2015 policy, that leading US centres say that there is a definition for severe pectus excavatum. If your Haller index is bigger than 3.25 and you've got cardiac compression on CT or echo, mitral prolapse, arrhythmia, that is the Kelly definition of severe pectus. And yet in the 2018 policy, it says there is no evidence for a subgroup that might benefit. Well, Kelly have defined a subgroup, and then they say there isn't a subgroup. They've actually put it in front of us. So I don't get how they say there isn't a subgroup. Secondly, they've only got 6 papers. Thirdly, they haven't got any papers with cardiovascular impairment. They actually excluded it from their search. So just to highlight that, this is cut and pasted from the NHS England Commissioning Policy, what they did for their PICO questions. What's PICO? PICO is patients, I interventions, C comparison, and O is the outcomes. What outcomes did they look for? They only asked their literature review team to look for psychological outcomes. And if you look in their search strategy, there is not a single cardiovascular outcome in there. So they've actually excluded all the cardiovascular outcome patients in their literature review that got that grand total of 6 papers for them to look at. So let's look at the other 5 papers that they included. So Luo from China is basically Boju's single surgeon series. It actually says in the paper this was a single surgeon series. In these 256 patients, it shows that mental health problems halved, depression dropped, and anxiety reduced. All of these had very significant p-values. And the NHS England were very into their we need to use a Bonferroni correction. So if you do lots of different categories, if you did 20 categories on a group, you would expect one to come out just by luck. And so you have to drop the p-values. They actually did they actually dropped it. NICE actually, well, sorry, NHS England did a recalculation, but even despite that, things came out positively in this study. So this is evidence of benefit for pectus, psychological evidence. So LOMHOLT from Denmark, this is actually Hans PILEGAARD's series. Again, one surgeon doing all the operations in Denmark in a single centre. And in this particular paper, they got controls. Again, NHS England were very critical of the lack of controls in the studies they reviewed. Well, there are controls here, very good controls. And there were benefits for emotional scores, health questionnaire, quality of life, mental health scores, and physical functioning also improved. So significant differences. This paper from Turkey, this is Mustafa Yüksel's group, and this is 88 patients, and they had huge improvements in psychosocial functioning after surgery compared to before, both by the patient assessment and parent assessments. And this is in the NHS Clinical Commissioning Review. They have reviewed this paper. This is a second paper from the same group by Mustafa Yüksel, a single surgeon that does all the operations. If you look at the paper, he's the only surgeon documented on this paper. And again, there were sort of, benefits for surgery, and there were operated and non-operated groups. And the last paper that they reviewed was another paper from Hans PILEGAARD. So they've got two papers from Hans PILEGAARD, two from Mustafa Yüksel, one from China, and multi-center review. And this one was a comparison with healthy controls. And there were improvements for emotional function, behavioural and mental health. So there were significant benefits. And again, they're 1 in 1,000, those p-values, showing significant benefits. So if I were to summarise NHS England's review of 6 papers, then they were all in quality of life. They only looked for quality of life in their literature review search. They actually excluded cardiovascular change papers. And they found 2 papers from Turkey, 2 papers from Denmark, 1 from China, and then the US Centre series. Of note, so all of them apart from 1 is single centre, and 1 specifically states, the Chinese paper, that it was a single surgeon. And I think we all know Mustafa Yüksel and Hans PILEGAARD. They pretty much did all their papers, their patients. So what did they miss? Well, it's mind-boggling what they missed. It's incredible. They missed just the highest number of papers ever. I mean, this is a disgraceful literature review. So let's go through some of the papers that they specifically excluded and why they excluded them. Hans PILEGAARD did a great paper. This is, I think, the best paper for proving cardiovascular benefit for pectus surgery. 49 patients had CPEX, which is the exercise test, highly detailed, echo, spirometry, MRI scanning. They had big Haller indexes, around 5, and they went and got 26 age-matched controls who had the same test, CPEX, echo, spirometry, MRI. And they didn't just do the healthy controls once, they did them over 3 years. I mean, there's no point doing that, but they did it anyway, just to get a better level of evidence. So before the operation, the pectus patients had 20% worse cardiac output compared to the controls. And then after the operation, they had exactly the same. Completely fixes them cardiovascularly. Now, I couldn't find exactly why this has been rejected by NHS England. It's either because of their 50 patient category, which actually they shouldn't have applied because they had less than 10 papers, or it's because there was no psychological benefits. They only had massive cardiovascular benefits in this paper. And remember, they were only looking for psychological benefits. So they should have included this study, I think. This is another fantastic paper from France by the group there. The Haller index again was big in this group. The repair was by Ravitch, which is not important how they fix it, but they did really good quality cardiovascular assessments, lung function echo, but most importantly and sensitively CPEX at 6 months and 12 months. So preoperatively they were only 77% of what they should have been. These patients were only 3/4 of what a normal person of that age and gender should have been. And then they did the same tests at 6 months of 1 year, and they improved. And the p-value was, so 1 in 2,000 chance of it being a mistake. So, significant improvements. The VO2 pulse increase was improved. They didn't show lung benefits, it was heart benefits. And also, interestingly, they did bubble testing on echo. And actually, there were 10 less out of the 120 patients who had patent foramen ovales. 20 pre-op and 10 post-op, amazing. But this was rejected. I don't know why. It doesn't say why it was rejected. I think it must be because they didn't do psychological assessment. It was only significant cardiovascular benefit as the reason for exclusion by NHS England. Dawn Jarolewski is probably the world's most proliferate surgeon in pectus surgery. She has a big practice in Florida in the Mayo Clinic, and she published 168 patients having NUSS procedures, all having transesophageal echo. She used some controlled transesophageal echoes in her patients that she'd already fixed, and she showed massive objective improvements. So, increases in the size of the right atrium, increases in the tricuspid annulus, increases in the right ventricular outflow tract, increases in right ventricular cardiac output, which weren't seen in control patients. So in the stakeholder review process, we put a load of papers in that we believe NHS England had incorrectly missed, and they rejected every single one of them. They did a very tiny one-line reason why they rejected some of them, and the reason for rejecting this one was a single surgeon performed all the procedures. That wasn't in their exclusion criteria, so I don't know why they said that was the reason they rejected this paper. Secondly, Luo, the Chinese paper that they accepted, was a single surgeon series, and I think most of us know that Hans PILEGAARD and Mustafa Yüksel did all the operations in the Turkish and the Danish series. So it's simply incorrect to reject this paper based on the fact it was a single surgeon series. David SIGALET and colleagues in Canada have written 3 papers in the cardiovascular improvement of pectus. They show improvements in stroke volume and also subjective exercise increases. And also they did find some lung function improvements. So NHS England have rejected 2 of their papers because they're out with their date range. But they did one in their date range, again showing exercise ability improvement and respiratory function improvement. We submitted this to NHS England and they rejected it. The one line they've said, results from single clinic site. Now wait a second, 5 of their 6 papers were from a single clinic site that they accepted. So that is an incorrect reason to reject this paper. This paper didn't turn up in their literature review because they rejected cardiovascular improvements. That's why this wasn't included. This is a really good paper from Germany, 2016. Loads of really significant improvements in right ventricular ejection fraction, right ventricular systolic volume, end systolic volumes, and even left ventricular ejection fractions in 38 patients having cardiac MRI before and after the NUSS procedure. Again, rejected. I don't know why. In fact, we could go on. Dawn Jarolewski has done a really good recent review in 2018 of papers that show cardiovascular benefit for patients undergoing pectus surgery. She has in fact documented 12 of these papers. Here is the table of more of the papers and the table of yet more of the papers. So there is a huge number. There's 12 papers documented here showing cardiovascular benefits of pectus surgery. Remember, none of these were included in the NHS England Clinical Evidence Review because they only showed cardiovascular benefits, and NHS England only searched for psychological benefits. Now, interestingly, on top of the papers that Dawn Jarolewski has documented showing clinical benefits, there is a whole literature on cardiovascular benefits according to MRI studies. This is one of the best. 30 patients having cardiac MRI with pectus excavatum, and they've got a control group, healthy controls, significant reductions in right heart ejection fraction. They even show some left heart function reductions, although those are smaller. And actually they commented that the changes they're seeing in the right ventricle looks like restrictive physiology. So there are some other heart conditions that squash or constrict the right heart, and this looks just like them. This other paper is a cardiac MRI study. There are quite a few of them showing right ventricular compression, reduced right ventricular function, tricuspid regurgitation, atrial compression. So the 12 papers that Dawn Jarolewski document, the ones that NICE threw out, and also the cardiac MRI studies all show that there is impairment of the right ventricle that can be relieved with surgery. Now, we also sent a load of case reports to NHS Clinical Commissioning. Now, why did we send case reports? Well, we sent it because if they're going to ban pectus for all patients, people like this in the UK will also have it banned. And they rejected them all because they were case reports. But we didn't have the ability to sit in front of that committee and say, you do realise if this patient turns up in Britain, you are rejecting surgery for them. And that is why we specifically said that was the reason we were submitting it. They just rejected it, and we didn't have the right to reply to that. So here's one. This patient could make herself pass out. She had such severe pectus. They did MRI scanning and tilt testing, and they could actually demonstrate this lady compressing her IVC when she straightened up. She had to live her life twisted to the left. And then Yaron Shargel did the operation, and it was completely fixed. They rejected this. This was another paper. 23-year-old woman collapsing on a weekly basis. Severe compression on TOE and CT, fixed by Ravitch. Rejected by NHS England. This was another one. He drops his blood pressure by 50 millimeters of mercury. The heart rate goes up, and the RV can be virtually obliterated if you do a TOE. And reduced ejection fraction of the right ventricle. Again, fixed with surgery. NHS England says any of these 3 patients, if they were in England, they should not have surgery. So if you look at the consultation report, a lot of people pointed this out. They document this and they even mention it. They said that there were lots of people saying that we should look for a subgroup, and it says here the respondents said there's a subgroup of patients with severely compromised cardiac function that would benefit from surgery, and their people were telling them that they should be considering this subgroup. But they said, although it's possible there may be a subgroup, i.e. Kelly told them the subgroup, no subgroups were identified from the literature. Wait a sec, they only reviewed 6 papers, none of which were in cardiovascular benefit. So they didn't look for this subgroup. They even saw the subgroup by Kelly. It's right in front of their face, and we sent a load of papers to them to show them that there is that subgroup that has cardiovascular benefit, but they have said they couldn't identify it. Well, that's because they didn't look. So in summary, the NHS Commissioning Policy said they couldn't find a subgroup with cardiovascular benefits, but they didn't look. They incorrectly rejected some papers, including Hans PILEGAARD's paper, including Dawn Jarolewski's paper, and they incorrectly rejected papers less than 50, because it said if you're going to get less than 10 papers, you should open that up. So they've got their literature review wrong. They only looked for psychological benefits, and then they've said they couldn't find a subgroup that could benefit cardiovascularly, and it really is a disgraceful state of affairs. So that is the literature. I think there is astounding evidence for benefit, both psychologically and cardiovascularly. I hope you agree. If anybody asks you, just refer back to this PowerPoint presentation. And please do fight for pectus surgery patients. Please do sign the poll that's out there trying to fight for restarting the petition that's for restarting pectus surgery, and let's all together see if we can turn this around. Thank you very much.